All right, here we are in part 2 of abnormal behavior across the lifespan. And in this video, we're going to look at attention deficit and disruptive behavior disorder. Disruptive behavior disorders includes attention deficit and hyperactivity disorder, conduct disorder, oppositional defiant disorder, and we're also going to look at anxiety and depression in childhood and adolescence. And then we'll move into the last section, which generally hits the adult population later in their lives, but it ranges, of course, and that is dementia, and we'll look at that as well. So this is the last video for this semester in abnormal psychology, and this is week 13 that I've delivered these on. Week 14 is the last test, so please don't forget, make sure you complete everything that's required, and good luck to you. I hope you've done well, and I hope you've enjoyed this semester. I've enjoyed delivering it, and please enjoy your holiday break and have a Merry Christmas. Bye now. We're going to look at attention deficit hyperactivity disorder, also known as ADHD. ADHD is characterized by impulsivity, inattention, and hyperactivity. ADHD can be divided into 3 subcategories. The first being inattentive type, the second being predominantly hyperactive impulsive type, and the third is a combination type. Usually can be diagnosed early in childhood and continue to be problematic throughout school. Now on table 11.3 on page 403 will give you some insights about that. And to check out page 404, abnormal behaviors breakout box, to give you some insights about attention deficit disorder. Now the theoretical perspective around attention deficit, there's no known cause currently. However, both biological and environmental are considered to be influenced. And now if you remember, those two combinations are a part of the Diathis model, so it's important to keep that one in mind too. Genetic and environmental look like multiple genes are involved, although small pieces of them. Twin studies have also been supportive of a genetic link. Areas of the brain that regulate impulsivity, executive function, appear to be affected. Now, some of this can be in the frontal lobe. This is at the front part of the, in your forehead, that area, that's your executive functioning. It's kind of like your office manager. And if it's understimulated, it's where you're easily distracted and find it hard to focus. The environmental elements can include exposure to secondhand tobacco smoke, appear to be a contributing factor, especially in vitro. Now, some of the treatment options, stimulant medication is considered generally effective in reducing hyperactivity, but it's not led to a general academic gains. However, it seems odd that a stimulant would help hyperactivity. It in some ways sort of works with the neurotransmitters in the brain, but we don't seem to know why it doesn't help with the understanding of ADD. Other strategies like behavior modification and cognitive modification have shown to be somewhat helpful. Now, what can be useful in certain terms of attention deficit disorder is to use something like a stimulant, like a Ritalin, as a window of opportunity to teach other skills so that medication can be reduced or withdrawn, and those skills have a tendency to stick. Now, another form of disruptive behavior disorders is usually what are known as conduct disorders. This is where a child will intentionally engage in antisocial behavior. Now, unlike ADD, where they are unable to control their behavior, conduct disorder typically extends into adolescent, where those with conduct disorder are more likely to participate in delinquent activities. Oppositional defiant disorder, ODD. Now this and conduct disorder appear alike, and in some ways they are. It is currently being looked at as a distinct and separate disorder, that is, ODD is. Notice the similarity in the definition in your text. When we consider the theoretical perspectives about oppositional defiant disorder, there are no known causes. Some suggest that underlying child temperament issues. Learning theorists suggest parent giving in too much and thus reinforcing oppositional behavior. Genetic factors may also play a role. However, there's no answers yet, and so we don't know. As far as treatment, of course, as you would expect, treatment remains a challenge as well. Systematic uses of reward and punishment, that's the behavioral approach, seems to be promising, as has cognitive behavior approaches of using problem solving and self-talk strategies have been useful as well. Now, within this same the category that we're in for abnormal behaviors across a lifetime, we can include anxiety and depression. Now, anxiety and fears are normal in childhood and for that matter in adult experiences. However, when it's excessive, persistent, and interferes with normal academic and social functioning, that is the difference for children and adolescents going through anxiety and depression. Separation anxiety disorder, well, this is when children with separation anxiety disorder show excessive anxiety for their developmental age. Showing anxiety is not abnormal, it's when it's above or excessive for their developmental age. When separated from their parents, some have excessive or unrealistic anxieties and worries, and separation anxiety often follows a stressful life event, something like a loss of a parent, either through divorce or death, a pet being lost, or changing schools. Now, when we consider the kind of perspectives around to explain anxiety disorders in childhood, like separation anxiety, psychoanalytic, they look, as in adults with anxiety issues, these theorists look to their earlier childhood anxieties and fears symbolizing some internal conflict or unconscious conflict. The cognitive model looks to cognitive biases. When interpreting ambiguous situations, are they biased towards expecting negative outcomes and coupled with negative self-talk? The learning model considers, well, how specific fears might generalize into broader themes like fear of failure, or fear of rejection. Now, depression in childhood and adolescence, depressed children, especially younger children, may not report or be aware of being depressed. Depression may also be masked by seemingly unrelated behaviors such as conduct disorder. Now, although rare, suicide in children does occur, and threats should be taken seriously. Risk factors for adolescent suicides is something we'll just look at here in the next slide. Or not the next slide, but the slide after. I just want to go a little further in this and then we'll move on. Correlates. Now, what's really important about recognizing correlates when it comes to treatment of depression in childhood adolescence, and correlates aren't answers or aren't causes. These are things that exist when things go better or when things occur. These seem to also be present, and that's what a correlation is. And so correlates are things that seem to occur at the same time. So as much as we don't know whether or not genetics is a factor, it seems to be an important variable. Seems to be more of a factor with adolescence, and more study needs to be done in a genetic role for childhood. Cognitive distortions play more of a role, as those who adopt a more helpless or permissive style of explaining circumstances increases the likelihood of a development of depression. And cognitive behavior therapy, well, there's been some good successes here as it involves the teaching of coping skills and social skills. Family therapy also seems to be helpful. So when we do consider suicide and the factors associated with suicide in children and adolescents, there's a number of features or factors that play a role. Gender. Girls 3 times more than boys will attempt suicide, while boys will be more likely to succeed. We noticed this when we talked about suicide with adults as being a very similar theme. With age, well, older young people are at greater risk than children. Young people between the ages of 15 and 24. Ethnicity plays a role. Aboriginal and First Nations children are 3 to 4 times more likely to commit suicide than the general population. Depression plays a role, and in combination with helplessness and low self-esteem. Previous suicide behavior, well, the risk is significantly increased if there's been a previous suicide attempt. 75% of adolescents who attempt suicide include the presence of family problems, whether this is instability, abuse, loss of a parent through divorce or death. Stressful events like unwanted pregnancies or breakup of a relationship or being arrested can play a role. Substance abuse by adolescent or a family member can influence children or adolescents and suicide attempts. And lastly, and kind of a curious one as it turns out, is one that's called social contagion. And this is where young people may romanticize suicide of others in what's called clustering, that others might commit suicide on the romanticized that this was a heroic act rather than a cry for help. Now the next area we'll move into, and the last area in this chapter, is looking at abnormal behavior across the lifespan as it occurs typically in older life. And here we're looking at dementia. And dementia is a form of cognitive impairment involving generalized progressive deficits in the person's memory and learning of new information, the ability to communicate, have judgments, and motor coordination. Now you'll find on page 418, table 11.5, the DSM-5 criteria. Now some of the reasons that we'll find that dementia occurs, we can include some brain abnormalities. Most notably, amyloid plaques. These are abnormally high amounts of protein fragments in the brain that the brain normally can clear out, but they accumulate and they harden, thus they're called plaques, and they harden between the nerves. And the neurofibrillary tangles, these are protein, this protein issue is in the nerve cell, inside the nerve cell, and it builds up like thread-like tangles, and it impairs the nerve cell's ability to repair itself. Now you'll see in the image there on the left what it is to be what a normal brain cells look like in the brain and what an Alzheimer's brain cells, and you can see where the plaques and tangles are. The images above one another are the PET scan examples of brain tissue. The neurotransmitter acetylcholine, it plays a role in memory, and the depletion of this neurotransmitter contributes significantly to memory deficits. Now, as far as causes, there are at least 50 different disorders that are known to cause dementia: Huntington's, Parkinson's disease, severe head injury, stroke, infection diseases, but the most common is Alzheimer's disease. Now, Alzheimer's disease is a fatal neurodegenerative disorder that accounts for the majority of dementia cases. There's no cures for Alzheimer's yet, although there's been many examples of things that are promising possibilities for the minimizing of Alzheimer's conditions, even speaking in terms of the potential cures, but they're years and years away. There are medications that seem to slow the decline of memory, language, and thinking abilities, but nothing that has a profound impact as of yet. Well, there we are, at the completion of Abnormal Psychology, and I hope that it's been good for you, and good luck, and I hope you enjoy your holiday break. Merry Christmas and Happy New Year.